I took the GRE once, did horribly on it, didn't really know how to study for it, forced myself to try and study again for it, did it again and barely got a better score. I was just felt completely ill-equipped after, studying German for 9 years and living there for a year. I wasn't planning on opening a private practice. When I finished training in 2021, I had done roughly half my training, all ironically under the supervision of psychiatrists. It just worked out that way where all of my mentors through graduate training were psychiatrists. After finishing school, ended up not working there, but there was another, the behavioral health hospital in Montana, the main one, was opening a clinic in Bozeman, actually. And so I applied for that, got the job, and was working exclusively with children and adolescents for the first year. Immediately get a release of information, call the therapist up, and just explain who I was and what my role is, that I was looking forward to working with them. And people have to be ready, just like coming to treatment for anything, people have to be ready for it, and not everybody is.
Welcome back to No Prior Auth. I'm sitting down with Ben Egbers this week. Ben is a psychiatric nurse practitioner at Access Integrated Mental Health in Colorado, where he runs some of the most intensive treatments in the field, deep TMS and ketamine, while believing something that sounds almost contradictory, that the goal is the least medication a person needs, not the most. Ben came to this work the long way. A psychology and German degree back in 2000, years as a case manager, teaching abroad, surviving an avalanche, and his own recovery from alcohol use disorder. And he didn't finish his nursing doctorate until 2021. He's open about all of it, and it shapes how he sits with people. I think this is his first podcast, so let's get into it. Welcome, Ben.
Thank you so much, Lindsay. That was quite the intro and absolutely accurate.
Okay, amazing. Other things I'm excited to hear about from you are the fact that you once were in private practice, your own private practice in Montana, right? And
Correct.
You are no longer.
Correct.
And you're also really interested in psychodynamics and how that can play a part in your PsychNP role. So I want to hear about the fellowship you're in and just more about your journey because it seems really unique. So I'm excited for people to learn more about you. So just to kick things off, tell us a little bit about just you as a person and kind of what got you into becoming a PsychNP.
Yeah, well, thanks again for having me. It's great to be here. And to your point, it was a bit of I going through your previous episodes, which were wonderful. I felt myself thinking, I'm a bit of an outlier here just because everybody's running very successful group practices and that sort of thing. And like I said, I'm honored to be here and get to tell a little bit about my story and journey. What got me into psychiatric nursing as far as as a provider, to your intro, my background was actually in psychology, and my original career goal was to become a clinical psychologist, actually. So my first aspirations were either a PhD or a PsyD, and became fascinated by manic depressive illness / bipolar disorder back in 2020 when I read K. Redfield Jamison's memoir, An Unquiet Mind, and that really was a life-changing book that really cemented my what I wanted to do research on, which was psychosocial interventions for the treatment of bipolar disorder. And so that was my original path. And I wanted to, similar to nursing, where a lot of nurses will go out and kind of cut their teeth, so to speak, metaphorically speaking, on med-surg. I did the same thing in community mental health. So graduating with an undergraduate degree in psychology, you don't have a lot of clinical training at that point. And so I really wanted to get some hands-on experience working in the field. So I worked with primarily at the severe and persistent mental illness population in community mental health. And it was an amazing experience. I still somehow remember the names of those clients 26 years later. But especially after all the drinking, which we'll get into later. Uh, yeah, it was just a very transformative experience. So and at the same token, a very exhausting experience to the point where after about, I worked for that organization for about 3 years, and eventually I just had to. I took the GRE, had everything set up. I was ready to apply to this program in Florida, of all places, which is part of the story. And I had just fallen in love with rock climbing at the time, and mountaineering and kind of the mountain sport lifestyle. And I took the GRE once, did horribly on it, didn't really know how to study for it. Forced myself to try and study again for it, did it again, and barely got a better score, and just wasn't really confident in the ability that it was going to be what I needed it to be to get me into the program, even though I had already talked to the advisor, the person I was going to do research for. But and the fact that I was looking at a 6 year plus commitment in Florida, of all places, and there are no mountains, no skiing, no rock climbing, to my knowledge at that. So I decided to pivot to plan B, which was to use my German degree. And so I traveled through Europe for the summer, climbing and hosteling my way across Europe with one of my best friends, climbing partner, who was in the avalanche with me years later. And yeah, decided to just stay in Europe and teach English, stay in Germany. So I did that and then came back to the States after a year and just floated around. I didn't really have a plan at that point. Nursing was the furthest thing from my radar. Worked in the outdoor industry for a little bit to kind of explore that, and then started a master's program in German studies here in Colorado. Actually, I relocated when I came back from Europe. I moved to Colorado. One of my best friends, who was my climbing partner at the time, and the guy that I mentioned regarding the avalanche, he was doing his PhD in physics here, and he said, "Hey, if you want a great landing pad, Boulder is an amazing spot. It's a great climbing town. It's a great singles town. It's great weather." So I came to visit and stayed here, saw it, and so yeah, kind of floated around, and then yeah, started this master's program in German because I had always wanted to go to graduate school, and that seemed like an easy entry into graduate work. And I knew after one semester, boy, this is the absolute wrong decision for me. I was just felt completely ill-equipped after, studying German for 9 years and living there for a year. So I came home for Christmas break that year. This was 2008, and talked to my mom, who was a nurse at that time, was kind of nearing the end of her career, and was talking to her about my kind of quandary of what to do. And she said, "Well, there's always nursing. It's a very, flexible career. You can support yourself. You can do anything." And that was enough to convince me. So I came back and told my German advisor, "Hey, I'm quitting the program. And I'm going to pivot to nursing," and started prereqs. And then that January, I think it was January 6th of 2008, my friend Mike and I were backcountry skiing, and an avalanche ripped loose above us in the backcountry, and he was buried. I had to rescue him, dig him out. We were the only two out there. I sustained pretty severe injuries myself. Both of us survived, but he was fully buried, and probably would have not survived. So yeah, came back, and I remember starting my prereqs in a cast sling because I had torn one of my extensor tendons. My snowboard had come off my pack and sliced through one of my tendons, and I couldn't write. So I had one of my the TA was actually doing calculations for me in this intro chemistry class, and anyways, yeah,
Wow.
got into nursing.
That's intense.
Yeah, it's quite the story. So, anyways, got into nursing school, went through a divorce at the time, and then, yeah, nursing for me, I thought I was going to be this pardon the term, badass ER
Hmm.
or ICU nurse, and high
Yeah.
adrenaline and all of that.
Hmm.
And got out of nursing school and got into med-surg and knew immediately, like, boy, the medical side is really not my forte. And I found myself just wanting to get out of clinical care. So I did a bunch of different things outside in industry and um, infusion pharmacy. So the first thing I did was I worked as a clinical like liaison type. So I was doing bedside education for an infusion pharmacy. So patients who were going home on IV antibiotics, for example, I would teach them how to use their PICC lines and how to use these different drug delivery devices and that sort of thing. And then I was also liaising with discharge planners. So there was a sales component to it. I remember very clearly laying awake at 2 or 3 in the morning when I was on night shift and just hating every minute of my med-surg existence. And I was like, I have to get out of here. So I found this clinical position. I was like, this sounds like a perfect exit. So it was weekends, it paid better, all that. Then I got sucked into clinical education in the pharmaceutical industry, which was high paying, which was also, intriguing to me.
As a
And then,
nurse,
yeah,
right?
as a nurse, still as a nurse.
Okay.
Yeah. And then
Interesting.
eventually I hit this point where I was just miserable, honestly. I was making a ton of
Mm.
money, but the work itself
Hmm.
felt very meaningless. I mean, I was trying
Hmm.
to um it felt like I was trying to ingratiate myself to nurse practitioners and physicians to log these calls that I was getting paid for and that sort of thing. And uh, yeah, I know you interviewed Danny Carlat, and that was part of what inspired him to kind of start Carlat Publishing, right? Was this sort of the inside knowledge of how things really are, not to disparage the pharmaceutical industry too much, but it just wasn't for me. I mean, I know a lot of colleagues and friends actually really enjoy their work. For me, it wasn't the right path. So I called my nursing school advisor and she was like, "Time for grad school." I was like, "I think you're right." So and I interviewed a bunch of different NPs, FNPs, AGNPs. Ironically, I didn't interview a psych NP, but I knew after talking to the AGNP and the FNPs that way of working with patients really wasn't going to be working for me. And what I really recalled most fondly about my patient interactions as a nurse was getting to sit down and hear their stories and hear about their difficulties and their struggles and how they made it through them. And looking into psychiatry, it's like that fits the bill, so to speak. So I took a huge pay cut, like 50 or 60 grand a year pay cut, and went back to bedside nursing in inpatient psychiatry. So started working as a traveler, local contracts, worked in residential eating disorders, and then worked in inpatient acute psych. Applied for the program, the University of Washington DNP program. This was in 2018 that I started, and then COVID hit, the world shut down, and yeah. So that was a little bit. That was a long-winded answer into what got me into or got me back into mental health or behavioral health.
Okay. Well, that's wow, quite a journey you've had. And I know at the beginning you mentioned, I'm an outlier compared to the other guests that you've had on, and that is kind of the point of why I asked you to be on. And also, I want this podcast to be about more than just private practice, because the truth is private practice isn't the answer for many people. And so, the fact that you had also had a private practice and walked away from it, I wouldn't have known that if we hadn't hopped on that quick call after connecting on LinkedIn. But I just thought that was interesting. Could you speak to that a little bit? Because I do think many people just kind of have private practice on a pedestal of sorts, kind of like, and there are benefits, right? And downsides, but I'd just be curious to hear about your experience.
Yeah, absolutely. I wasn't planning on opening a private practice, honestly. When I finished training in 2021, I had done roughly half my training, all ironically under the supervision of psychiatrists. It just worked out that way, where all of my mentors through graduate training were psychiatrists, and so half of it was with adult psychiatrists and all outpatient, and then the other half was with child and adolescent. And part of that was very much intentional on my part. My wife and I knew that we wanted to relocate to Montana and get out of the busyness of Seattle, and so I interviewed or kind of networked with a private practice in Bozeman, and there was a child psychiatrist there, Raven Littmanson, who I became a mentor, and she was one of my supervisors, and we were talking about plans after school, and she said, well, we'd certainly have a need for someone who's willing to work with children and adolescents. And so, yeah, thought, hey, it's something that I'd never really given much thought to. But after working with her as a student, it really became a enjoyable and kind of natural fit for me. And so after finishing school, ended up not working there, but there was the behavioral health hospital in Montana, the main one, was opening a clinic in Bozeman, actually. And so I applied for that, got the job, and was working exclusively with children and adolescents for the first year. And then, Montana is a very rural state, and there's a huge dearth of providers overall. And it felt like I really wanted to be able to serve patients across the lifespan, and the only way to do that was to open a practice. And so I did that just I think it was like one half a day a week I started, and then grew from there. And then eventually the child and adolescent clinic actually closed. And so I pivoted to the practice full time. And our family was getting insurance through my child and adolescent clinic job. So I took a teaching position actually with Montana State University. One of my colleagues who I'd spoken with about a year before, who was another nurse practitioner in Bozeman, but was also on faculty at Montana State University, Wade Hill, who's a wonderful individual, really a well-respected leader in that community. He said, well, we always have, we're always looking for, people who would be great for the teaching role here, and I think you'd be great. And so he had me interview, and I started teaching in the DNP program there on the clinical side. So yeah, that was sort of how. And so I was at one point I had all three jobs, and then the child and adolescent clinic closed, and then I was down to two jobs, but both of them very much felt like full-time jobs, and so it was a lot to manage. And in my practice, Wade was kind of my mentor as far as private practice. And so I sort of followed his playbook, and he did everything himself.
So he's in private practice.
He's in private practice. Yeah, he's currently still in private practice. He's since then retired from his teaching position because he'd been with the university for many years. But yeah, so I ended up using the same EHR as him.
What was that?
That was it was called Icon Notes, which is this very I was trying to do everything on the cheap, as far as the lowest overhead possible, which in the end, looking back on it, may have not been the smartest decision. But again, I was just sort of following his lead, and he seemed to think it was good enough for him. And so I thought, well, if he's using it, it must be fine. So, and it served its basic purposes. It had an integrated clearinghouse, which I knew nothing about clearinghouses, about the CMS 1500 form, about how nurse practitioners get paid in practices, billing codes, all that stuff. I kind of learned that all on the fly. So.
Okay. Wow. Are you familiar with Eric Arzubi?
Just random. I am, yeah. Actually, yeah. I'm connected with him on LinkedIn, and he runs Frontier, who actually one of my students when I was teaching now works with Eric at Frontier. So.
Oh, really? That's cool.
Yeah.
Okay, that was a connection that, like a warm intro that Dr. Carlat had made for me, and So I was just kind of curious because
Yeah,
he
yeah,
seems like an interesting provider. And also, it's been hard for me to find providers to connect with, like psych NPs and psychiatrists in Montana for some reason.
mhm.
So that just like intrigued me that that's where you were from and, are kind of familiar with the community there.
Yeah, I'm happy to. I know several more, so happy to connect you with those offline. Heather Zalewski was the medical director at the time of the hospital that I worked for, and she was my main supervisor in the beginning. And she's wonderful, very knowledgeable, and um, uh, yeah, driving force in psychiatry in Montana. So
Would you have a
yeah,
child?
3.5-year-old Fremont. Yeah, our son Fremont.
Oh, that's awesome. That's really cool. So you know the balance of parenting and being a clinician and everything like that. I was going to ask just like one last question about the private practice experience. What was like your favorite part of private practice and the thing you didn't like the most about it? And would you ever consider it in the future?
Yeah, I would consider it in the future, certainly. And what that may look like in the future, I'm not quite sure. But the thing that I think the thing that I liked the most about it was the community engagement and the partnering with. I mean, I never had a Psychology Today profile. Um, it was all through networking, primarily with therapists that I had collaborated with before with patients. I mean, that's probably one thing that I value the most in the work that we do is the partnerships that I mean, psychiatry is a team sport, right? And
Mhm.
yeah, to me it is.
Yeah, no, absolutely. Any practical tips when it comes to networking with therapists? Because I think you're exactly right. And I think there's an art to kind of making those connections and collaborating. And I was just curious if you had any practical suggestions or ways that you've practiced that have worked for you and led to, good patient referrals and whatnot.
Yeah, I mean, I feel like my intention usually when I start working with a new patient, if they're already set up with the therapist and they have a wonderful working relationship with the therapist, I immediately get a release of information and just explain to the person the work that you're doing with that therapist is invaluable. And I always kind of used to joke with people that like the therapists are doing the heavy lifting, so to speak. I mean, they're with those patients week in, week out, for hours and hours. For most of us in psychiatry, we're doing 30-minute med checks, and we can do some supportive psychotherapy in that time, certainly, but oftentimes we're not getting into the real depth of what the person is struggling with. And so I would, yeah, immediately get a release of information, call the therapist up, and just explain who I was and what my role is, that I was looking forward to working with them and really wanting to work collaboratively together to make sure that we're not like working against each other in strange ways, or that we're aligned in certainly our diagnostic formulations and our clinical conceptualization of what the core issues are with the patient. So that was probably the thing that I enjoyed the most, was building those partnerships. And I think the work that we do, that's probably the best advertising we can get, because if this person is we're showing up and we're working collaboratively, that therapist is probably going to be more likely to, if one of their clients comes to them and say, "Oh, I think I'm ready to try medicine," they're going to think of you of being this like, "Oh, this I should send this person to, this provider because they are they're willing to work together." I've heard lots of therapists tell me, "You're the first psychiatric provider to reach out to me. I mean, this person's had multiple psychiatrists and other nurse practitioners, and for whatever reason, they just tend to not want to reach out." And that's always surprising and somewhat disheartening to hear. So,
Yeah. And are you picking up the phone or are you
oh yeah,
like, yeah, okay. I think that's
absolutely.
also a big differentiating factor. You know what I mean? That like, yeah, you're willing to take the time to reach out. I think that goes a long way.
Yeah.
Um, Okay,
So
so
yeah, the thing that I disliked most about it uh, was the billing. I mean, I spent
Mhm.
countless hours on the phone with various payers trying to sort out why this claim didn't get paid. And sometimes it was
Mhm.
like, oh, you forgot to add the GT modifier to the 99214, and that's why that's why we didn't pay. And then you have to go through this whole process of claim resubmission and
Yeah.
doing it in a certain way. And that part just that sort of killed any desire to do
Mhm.
it again. So,
Yeah, that
yeah.
makes sense. That makes a lot of sense.
Yeah.
Um, talk to us a little bit, if you don't mind, about just your journey in recovery, and
Yeah.
just how that's been as a provider.
Mm.
Because I think it's really brave and important when clinicians who have dealt with that are willing to share more about their stories.
Yeah.
And I think,
I
yeah,
agree.
you can really help that population a lot of times, even more so, I would say.
Yeah. Yeah. Um, so yeah, I mean, actually it'll be the 20th this month that I'm celebrating 10 years of sobriety. Um, thanks. Yeah. Hard to believe. And I was, yeah, just talking to another friend actually who's struggling with their drinking. And yeah, I was just kind of reflecting on like how crazy it's been that it's been 10 years. But it was not planned. I mean, it was something that I'd always, grew up in a family where there was problematic drinking and alcohol use disorder. And yeah, just sort of fell into it myself, started drinking in high school, that progressed through college. And I was always a very functional drinker, so um, was always employed, didn't have any legal problems. So I had this sort of idea that it was under control or it wasn't a problem, and yet at the same time have countless memories of thinking, well, I got to slow down. I should, I'm getting too old for this, so on and so forth. All the things that lots of people go through in their journey. And what, the stopping part was totally unplanned. I mean, it was really it was actually Father's Day of um, 2016. Yeah. And I remember waking up. That weekend was a big drinking weekend for me, big drinking Friday night, a graduation party. A friend of mine graduated from dental school Saturday night, late night Saturday night. And I woke up Sunday morning hungover and was just like, I can't do this anymore. Like it was that sort of, in AA, you hear the term surrender a lot. And it was kind of this surrender moment where I was just like, can't do this. I don't know. I don't have a plan. I don't know what I'm going to do, but I just can't do this anymore. And so I called a therapist that I'd seen about a year prior who was had a history working in the substance use industry or world. And when I saw her, it was through an employee assistance program. And she was like, well, I'm not, if you're going to be drinking while I'm seeing you, I won't see you because, if I'm going to work with you, you need to be not drinking while I'm seeing you. And I was like, sure, I can do 8 sessions and not drink over the course of those 8 weeks. No problem. And I did. And then as soon as the 8 weeks were up, I went right back to it. And I'd heard various things from various therapists over the years, like, oh, if you can quit drinking for 30 days, you don't have a problem. Or if you can quit for 90 days, you don't have a problem. And I would always make it to like 87 days or, 29 days and throw the towel in. Like that was like, oh, that was good enough. I don't have a problem. And so anyways, I went back to this and I said, I think I'm ready to quit. She's like, oh, good. When are you going to go to treatment? And I was like, whoa, 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 treatment. I'm a high end beer snob. Like I'm a home brewer. You know, I, I was really big into the brewery scene in Seattle. I was like, I don't need treatment. I'm not like drinking pop off vodka out of a handle. And she's like, I think this is going to be harder for you than your anticipating. And I think if you try to do this on your own, you're not going to be successful. And I was like, okay. I paused and, thought about it and looked into my insurance and was like, all right, well, if this person who has clearly more experience in this world than I do, I'm willing to, take her at her word. So I found an intensive outpatient. So that was during my pharmaceutical role. So I was traveling a lot and I needed something that was flexible. So I found this intensive outpatient program that was in Seattle, that was in the evenings, more holistically based. They, used yoga and meditation and that kind of stuff. And um, that is, I'm a practicing Buddhist and wasn't at that time, but meditation is something that was always interesting to me and something that I wanted to explore more. And so I
Yeah.
started that program and yeah, did that for about 11 months. So
Wow. Quite a journey that you've
yeah,
had.
good.
And how has it been? Like, do you find that that's a population you really enjoy helping now, or how does it affect like your kind of current
Yeah.
day
Yeah.
psych NP
Yeah.
practice, I guess?
Yeah.
And then we'll pivot to psychodynamic stuff because
Sure. Sure.
I want you to educate me on that because
Yeah.
I don't know that much.
Yeah. 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 How it shows up or how I approach it in practice is, I try to use, I mean, it's part of our everyday assessment, right? Like that's part of, should be one of the main questions we're asking in a psychiatric interview is there any substance use that could be contributing to these symptoms that you're coming to me with? Because if that's the case, then that's needs to be addressed. And, so, uh, I think I have a unique perspective in that I've kind of walked through that fire myself and um I think it gives me a unique perspective as to what the person might be struggling with. And I wouldn't say that I'm someone who actively seeks out people who are actively struggling with substance use disorder. Um and part of that is because I think people have to be ready, I mean, just like coming to treatment for anything, people have to be ready for it, and not everybody is. And certainly I think the people who are ready for it who, in some degree or another, there's a little bit more to work with there, I
Yeah.
mean, motivational interviewing, sure, is wonderful and very important, trying to assess where people feel like they're at, with regards to their substance intake. Um, but I think the people that I really, really, that I've found to be, um, I don't know, I guess the most ready for treatment are the people who are at that point where they're like, I know this is a problem and I really want help on this. I just don't know what to do. Um, and yeah, sometimes I will self-disclose, if I think it's going to be helpful to the person, and just let them know, hey, these are some options out there, and I can speak from experience that, if you're not an AA person and you don't want to go to AA, and then don't go to AA. There are other options, and AA can be really helpful for some people, even people who are resistant to the idea or freaked out about the whole God thing. That's usually a big sticking point. It's like, I don't believe in God or whatever, or I don't want to be told what to do. Uh, so through exploring that, you can kind of tell maybe who might benefit from it more so than others. So
Yeah.
I don't know if that answers your question or not,
It
but
does. It does. It absolutely does. That's insightful. So tell
mhm.
us how you got into the psychodynamic world
Yeah,
and yeah, just talk to us about that. And again, I don't know a ton about it, so just keep it basic for those of us who aren't really familiar as psych NPs, what it means to practice in that way.
yeah. So I mean, everybody's heard of Freud, and Freud was sort of the the modern originator of modern psychotherapy, right? He kind of developed the talking cure. And I hesitate to speak too authoritatively on this because I'm not an expert by any means. I'm still very much in the beginning stages of learning about this. But I mean, I remember learning about psychodynamic principles in the unconscious back as a psychology major. And I think through that program and even through nursing, uh, the psychodynamic approach, I think, is experiencing a bit of a renaissance right now. I think it's, I mean, on LinkedIn, I certainly, and maybe it's just who I follow, but I'm seeing a lot more interest in it and a lot more psychoanalysts posting about it. But at its basis, it's really about this idea that, there's this thing called the unconscious, right? This part of the mind called the unconscious that is kind of, I don't want to say that's where these things like wishes, like drives, like defenses exist, defense mechanisms. And, I think as I understand it, this general principle is um, these symptoms that people come to us with, it's a way that the mind is communicating something that's going on that the person's not aware of. And um and everything has meaning. I mean, everybody's heard the term the Freudian slip, where we mistakenly say something that we didn't mean to, that has maybe some underlying meaning. But dream slips, behaviors, body language, all of that has meaning. And it's a way of the mind communicating to sort of the outside world what's going on that the person's not aware of. And through psychodynamic therapy and psychoanalysis, which is a much more intensive form of psychodynamic therapy, where the person's seeing their analyst 4 to 5, somewhere between 3 and 5 times a week for 45 minutes. And the basis for all of this really is, the idea that early childhood experiences and early childhood relationships, oftentimes with the person's primary caregiver, something went maybe awry in one of the developmental phases that the child goes through, and really through adolescence and even into adulthood. But those formative experiences early in life, based on the relationship with the caregiver, the parent, oftentimes the mother, sometimes the father, sometimes both, something is amiss. And as a result, the person becomes developmentally arrested to a certain degree in that phase. And that plays out in future relationships. And so as the analyst or the therapist is listening to this person in therapy, they start to recognize patterns in relationships, in job changes, in things like that. And then through asking about the person's experience in early childhood, oftentimes these insights can come about. And so the other piece of it is really to help the person understand how their mind works. And it's much less focused on the diagnosis according to the current DSM system. I mean, I'm looking, actually, my laptop is stacked on top of a very thick book called the Psychodynamic Diagnostic Manual, who's partially written by Nancy McWilliams, who, if viewers are interested, she is a wonderful resource if people are interested in learning more about psychodynamic therapy theory. Nancy McWilliams is, she's just very readable. She breaks things down into very digestible size pieces that are more easily understood. I would say, don't start with original Freud if you're interested in psychodynamic theory. It can be complex.
Yeah, absolutely.
So,
This is kind of a random question, and if you don't want to answer it, you don't have to, but have you
yeah.
ever been through it on the patient side of things?
Not a full analysis. I mean, my therapist that I see now, is a psychoanalyst, and I think down the road there's certainly an interest there. I mean, I have I have my own hangups and baggage and issues and things that I struggle with in my
Yeah,
life and my
we all do.
marriage, and
Mm-hmm.
and being a parent, and I'm sure that a lot of it kind of harkens back to my own childhood, and I mean, right now I'm just doing psychodynamically oriented therapy once a week with my therapist. I'd like to increase it to twice a week, and the general, the other piece there is the relationship that forms between the therapist or the analyst and the patient can take on this almost, I mean, everybody's heard of the term transference and counter, or maybe not everybody, but countertransference and transference. Transference is the reaction that the patient has to the therapist,
Yeah.
and countertransference is the relation, or is the reaction that the therapist has to the patient, or the feelings that are brought up in session. And that relationship can very much take on, or can assume this, yeah, I don't want to say parental type role, but if the initial injury that the person sustained in childhood was between themselves and their parent, the therapist's role is to kind of take on this, parental type figure, so that that person can kind of act out and explore these dynamic issues in a safe, contained space, and ultimately, sort of I don't want to say triumph, but heal from those experiences early on, with the therapist kind of functioning in that pseudo
Mm-hmm.
parental role. So,
Okay, interesting.
yeah.
So, what would you say to psych NPs who are still in school or maybe they just graduated as far as the realm of psychodynamics?
Hmm.
Like, do you think that this is something that all psych NPs should know a little bit, a lot of a bit, like what resources to go to? Like, I
Yeah.
think it feels kind of like out of reach
Yeah.
for,
Yeah.
if that makes any sense.
Yeah. Yeah. No, it does. I mean, if you look at, and I don't want to compare it to medical education, but I mean, psychiatrists, psychiatric residents oftentimes will get psychotherapy training in, cognitive behavioral therapy, psychodynamic therapy, and then like interpersonal therapy oftentimes. I think it's important to be at least aware of psychodynamic principles, because inevitably in our work with patients, they will evoke feelings in us. Sitting
Mm,
in session with them, and we kind of feel like, gosh, why am I getting irritated by this person? Or I really just want to run out of the room right now. Like, this person is putting me on edge. I don't know, I'm feeling suspicious. I'm feeling, like, so that's all counter transference, and these patients will be, and we'll be doing the same thing with them. I mean, we'll be interacting with certain ways with them, and they'll respond to us in certain ways. And I think one of the beautiful things about the psychodynamic approach is it really digs into that. And it so informing ourselves on basic principles and ideas like transference and countertransference, and the frame, setting the frame, which is it's kind of its own skill.
mhm.
The treatment frame. I think there are certain aspects to. It doesn't mean you have to go all in and go on for full psychodynamic training, but I think it's certainly helpful. Just like it's helpful to know about the CBT triangle and be able to explain that to patients, and have a handful of DBT skills that we can help people with who are struggling with emotional dysregulation or interpersonal ineffectiveness. So I
Yeah.
think it can be really helpful for as a skill set.
Yeah. Okay. That's helpful. My
Yeah,
listeners want me to keep these episodes shorter, so I'm going to wrap up in the
sure.
next, but I still really want to hear just briefly about like you're in this Brooks Fellowship, and then also you're getting ready to go into something else. Can you just tell us about
Yeah.
those real quick? And then,
Yeah. So
yeah.
a plug for Brooke Finley's psychodynamic psychotherapy fellowship. So um, I think I remember hearing about it a while back just through following her on LinkedIn. And then a friend of mine who's another, nurse leader, Rowan D'Erico, he reached out to me and said, "Hey, are you doing Brooks Fellowship?" And I hadn't planned on it. And then doing a little bit more research, it just sort of, I was like, yeah, I think this is a really great next educational step. And so it's been a wonderful, incredibly informative 9 months, where we gather once a week, and there's a reading assignment for the week, and we get together and discuss that and discuss. Brooke is a really wonderful teacher, and is incredibly experienced in that field, and is a leader in herself. And so that has been a great jumping off point for more training, for me anyways. And actually, per her recommendation, the program, so I decided to go on for another 2-year combined didactic. So Brooks Fellowship is primarily didactic in nature. There isn't any clinical supervision or anything associated with it, but the program that I'm going into, which is the Contemporary Freudian Society Psychodynamic Psychotherapy Training Program, which is a 2-year program with didactic as well as clinical components. So there's included supervision. It's expected that you're going to be doing psychodynamic therapy with patients. So that, yeah, I think that's the next step. And whether I go on for full analytic training, I'm not quite sure down the road, but that's a whole another undertaking of significantly more time commitment. But I'm going to start with this to start mixing it into my practice and
Yeah,
see how it goes.
that's really cool. Thank you so much for sharing more about that.
Yeah,
I definitely want to have you on for like a part 2 episode because I feel like we just scratched the surface with some of this stuff. But I totally understand people, liking those shorter episodes.
absolutely.
One last question I ask all of my guests. What
Yeah.
does the term no prior auth mean to you?
Yeah. After watching your other episodes, I was like, I need to come up with some really deep, witty answer about this. I think I woke up at like 4 in the morning this morning, like pondering that very question. I was like, boy, you got to come up with something
Oh,
today.
that cracks me up.
Uh, so I think, a couple things came to mind. One was it's easier to ask for forgiveness than it is permission sometimes. Um, and I think the other sentiment that comes to mind is, yeah, we shouldn't have to ask for permission to practice according to our values and
Mhm.
to do
Well
what we
said.
feel is right for the patient, and
Well
sometimes
said.
that is a segue for part two in terms of
Mhm.
this transition away from um, the interventional side of psychiatry, which I've been practicing in for the last year, to more of
Mhm.
what feels like a little bit more authentic for me as a, working in a group practice, but getting to do a lot more therapy.
Right. Okay. Awesome. Yeah, we definitely will want to hear more about that too. So, well, thank you so much, Ben, and we're looking forward to having you back for another episode down the line.
Sounds great. Look forward to it.